MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming. Hey, welcome to the MedBreaks webcast. This is Rama Vaghmare. I'm the host for the MedBreaks. So I have a very interesting program today. I'm going back all the way to my hometown. It's a relatively hometown. It's in the home state. Maybe now it's not even a home state. We divided into the two states in Andhra Pradesh. So my home state is Andhra, but Andhra Pradesh used to be United States. So I'm going back all the way to my native land. Okay, so I'm going to talk with a physician from there. The cancer is in India relatively lower at the age standard. If you take the age standards, cancer rates are very lower, much lower than the standards in the world. I mean, the rate in the world. So that's a good news because there could be detection problem. It could be diagnosing or prognosis. All these things may not be doing all together, but relatively lower in India because we are all young population in India, most of them are. So there's also that the lot of vegetarianism is one of the helpful, they say. So these kind of things we don't know yet, but India is a relatively lower incidence of when you compare the age standards, is a lower incident rate. But the biggest problem is screening. Screening is the biggest problem in the breast cancer, lung cancer, and the cervical cancer and prostate cancer. All of them are screening things is a big problem, particularly rural health areas, because that is a challenge itself. There's a huge amount of resources required. We don't have that resources. So it is a struggle. In India, the cancer, probably they come to the big cities by stage 4, stage 3, by the time they come down to the big cities. It is a challenge. But actually, before I introduce my guest, the thing is that we have a very prominent scientist contributed to cancer research quite a bit. I presented a topic on C.V. Raman, Chandrasekhar Venkata Raman, who is a Raman spectroscopy, is a contour of the cancers. They do like that, is one of the diagnostic medicine said that one of the powerful quantum phenomena that you can be in the future is going to come you can go to a drugstore and can probably scan that one and get the cancer results right there. That's the Raman spectroscopy. The other one is actually Aragobind Khurana, who is a 1969. He won the Nobel. Both of them won Nobel Prize. 1930, C.V. Raman won the Nobel Prize for Raman scattering. The 1969 won the Aragobind Khurana. He won the Nobel Prize for the genetic, the synthetic gene, the creation. But anyway, cancer is a big problem. Is growing. Is one of the there is an unmistakable thing is among the youth, particularly the young people, are getting more and more exposed to cancer. Let us talk with another young woman from Hyderabad joining. Her name is Rama Vaghmare from Hyderabad, Sikandrabad. The twin cities. Welcome, Rama. Welcome to the MedBix webcast.
Thank you so much, Mr. Annam Raju, for having me here. I feel delighted to get connected with somebody who belongs to the place where I live, and I think you should be visiting Hyderabad very soon. It's been like very long. As you said, you left to states, but I'm glad that we connected, and definitely connecting talking about talking about a topic that is like really close to my heart, and that is what I do on a daily basis. So that is thank you for that.
So before you get into just giving me your background, just what is your personal background? What qualifications and
like as you've already introduced, I am like recognized by name Dr. Rama Vaghmare. So from childhood, it's been like I did not actually think that I should be a doctor or a clinician. I did not think of, but during the course of time, when I was in my 10th standard, and there was a point where I like severely fell sick because of severe anemia and hospitalized in a government hospital. And looking at the infrastructure, I was like so pissed off, like, okay, what is this? It's so unhygienic, and I couldn't take that. So just my father, he just said, he just passed a line. When of course I recovered quickly. I recovered in a matter of months. But then when I was undergoing treatment, he would say that my daughter also should become a doctor, so that at least she can, whatever challenges we are facing, to access, or to receive the health care, so that, and at least she can do her best to minimize that, or she can improvise at her level whatever best. So that point somewhere, that stuck in my mind, and I always like, okay, I need to crack MBBS, I need to get into MBBS. So that was something like just a background, maybe in the subconscious. I never spoke about it, but then it was somewhere in the subconscious that, okay, I should, maybe I will become a doctor. And then the journey began, of course, because I'm from Hyderabad. I had to grab a government seat, free seat, as you know, like I joined my MBBS in the way back in the year 2006. So at that time we had an entrance exam called MSET we had to give, and based on the ranking you would be allotted the top priority colleges. And I mean, touchwood, my hard work, reaped fruits, and I could join a government medical college, Kakatiya Medical College, which is 150 kilometers from Hyderabad. So that journey was very fascinating. MBBS journey had been a turning point in my life. There were coming as a kid, I was like, very succumbed, very what you call, never not that confident kid who would get, be open to talk about anything, or my self esteem was really low as a kid. But MBBS was a turning point where I learned a lot of things, and especially that college environment, that particular 5.5 years, that is a golden period of my life. That is where I decided I'm gonna turn into a woman that, going forward, many girls would be taking an inspiration. At least I don't know to what extent I've been able to do that, but definitely I have. I feel empowered right now than what the girl was there way back in 2006. And after completing MBBS, so again there comes a challenge whether I should do a super special, specialty, or just be an MBBS physician and continue whatever. So again, that was a big question mark that every graduate, MBBS graduate, would come across. But then I was very clear, okay, I need to do then I did my own research, and I was very clear I need to do some specialty. But I was not clear what specialty. So it came just I mean, out of nowhere, in the based on my ranking, I had an option to choose between anesthesia and radiation oncology. These were the only two options left for my rank at that time in the year 2014. And I was like, okay, should I like go ahead with these options, or should I wait for one more year, uh, you know read for one more year, do the preparation and all. But somehow at that point, it was just a vague decision that I took. There was like no thought process in why I had like I'll be like really honest, like why I got into radiation oncology. It is so, but then the moment I joined this specialty, the first 3 to 4 months, I was, spellbound. What I was seeing, see, as an MBBS graduate, the amount of patients you see, the type of patients you see, the interaction, it's completely different. And coming to an oncology ward, it completely, like, in the first 3 4 months, in fact, I was a little bit disheartened. There is like so much grief, and there is like a lot bad that is happening in healthcare, and we doctors are helpless. That was my initial thought process. But then when I spoke to my seniors, professors, they had like guided, that is what we are here for. We are here to change that reality, that we can add some quality to the people who have lost hope in their life. So that motivated me. And okay, then somewhere you see, okay, whatever decision directly or indirectly you take, that happens for good. And I felt really fortunate to step into that step into this particular specialty then. and the journey has been like very, there has been like a lot of sweet moments, bitter moments, but it's been amazing.
And another thing you mentioned just now off the camera, that you said that in India, the woman or the most number of cardiologists, sorry, radiation oncologists, is the woman is more higher than
Yes.
men. That is a very surprising to me. Tell us a little bit about that, if you don't mind.
So even in fact, like even we as for the statistics, we also were like not aware when we were like joining, but of late, like there has been like when see in the city we estimate like the statistics would be more like what are the job opportunities here, like who's going to join where, and what would be your career path after you finish your MD. That is what is important, right? After the 3 years of your specialty that you do. So then we realize, the count in Hyderabad, like when you see there are like a lot of women radiation oncologists. And apart from that, we have a census where there is a association of for any specialty. There is an association, there is a local body, there is a national body that is there. So the head count of females is more, and that is very the that's very interesting, because we feel fortunate, we are able to empower this department with leading women, as a leading woman.
That is a very good news. I mean, around the world, that the woman has a more number in radiation oncology. That is a lesson for the world itself.
No,
It's
this
we are
statistics would be different in non-Indian countries, but India it is somehow like that.
okay.
More girls are in this particular oncology subspecialty.
Very good news. Let me ask you. So let us talk about the sad part of the cancer screening, starting from a rural India. I know the big cities, they have all the infrastructure there, plenty of infrastructure in big cities, Hyderabad, Chennai, and all those places. But what is the state of the small rural? You went to Kakatiya, Varangal, or some small places. If you go further down, small areas, what are the screening? First, let us talk about screening process. Are there any screening available? Are there any mobile units are now doing the screening? What are the situations now?
So in India, there is like complete different scenario. Like you have been like mentioning yourself, when it comes to urban and the rural counterparts, there is like a lot of difference existing even now. So in the rural parts, even there is like limited awareness and education. Many rural populations have limited they don't even know how important it is to talk about cancer, or what measures they have to take, or uh, people are not even aware that there are some screening modalities for cancer available. That is mainly it is because of lack of awareness and education, and also the accessibility. So see in tier 2 cities and the rural part of India, nowadays you have like lot of big hospitals coming up. There are like specialty doctors there, super specialty doctors are there, but then when it comes to oncology, somehow the accessibility is limited. And the rural and the distance also, like they have to travel far off if they encounter a cancer diagnosis, or they have to get anything done with regards to cancer, they have to travel far off. So that is also one of the challenge. And like as I've been mentioning, healthcare infrastructure is not there in the rural area. And apart from infrastructure, the one more important thing is that lack of trained professionals to connect with the rural population.
Hmm.
So rural population, they actually if I'm pretty sure you would like agree with the fact that they connect with people who, if they like trust them, they connect people with heart. They do not actually like upfront give them the explanation, the logistics. Somehow that is not the way you reach out to rural people. For rural people, you need to establish that trust, that belief, to develop that connect for them to come forward and talk about any issue, not about cancer, but for regarding any issue, you need to trust them. So lack of trained professionals at the rural level is not there.
An
So that
excellent
is
point.
what
It's an excellent point. But I wanted to ask you, some of them are may not need a infrastructure, basically education, self exam for breast exam for self examination, all those things. Are they training? That is still evolving that process? Are they providing some kind of a training to the basic symptoms of the cancer, basic screening for the breast exam, self examinations? Are they education itself moving? That's at least the first step. You could do that. Is it moving in the right direction there?
Yes, I mean, right, in off or to date, it's like, things are touchwood moving in the right direction. There have been like lot of initiatives that government has taken, along with, non cancer is also one of the non-communicable disease like hypertension, diabetes. To prevent this non-communicable disease, there have been like lot of prevention programs for control of cancer that the government has taken initiative. So it is to the aim of these programs are mainly to strengthen the infrastructure and provide training to the healthcare workers. So we have been like talking about the major challenges: infrastructure, accessibility, and healthcare workers, I mean trained healthcare workers. So government initiatives are trying to focus on the primary challenge. And also, like, as you mentioned, for cancer screening we do not need specific infrastructure or a big building, a big machinery, or something of that sort. So cancer screening is something with basic planning, with proper planning, that can be like tackled. So what is happening these days is a lot of mobile screening units are installed, or they go to the villages to do the cancer screening. So mobile, it is like, you can it's a vehicle which will be having the basic testing equipment that will be required for cancer screening, especially for breast cancer, cervical, and oral cancers. So they go, I mean, they do the screening test for the local population there, and they get back the samples, they test, and if anything comes in that, they would the local population would be intimated about it. Because these days, one good thing is that the technology in rural areas has also increased. So everybody has access to smartphones. So if anything is there, people are reachable over I mean, just a phone call away. If anything is there, if you have to inform them about a cancer diagnosis or something is needed, we can definitely reach out to them. And the by this, what we can have a good database of the these days, it's possible to have a huge, you can have the database of multiples in thousands and lakhs. So that is one of the good things that will help in improvising this cancer screening part.
Rama, what kind of cancers you see in general in India? What are the most prevalent cancers? Just again, run down on that one a little bit.
So the common cancers in India, like, we usually divide it in men and women. So in women, the most common cancer is breast cancer. This has been like this has changed recently. Initially, few years back, cervical cancer, no, the cervical cancer used to be the predominant cancer in women. But because of the lifestyle changes, most of the Indians are moving towards westernization, lifestyle. They're like adapting a sedentary lifestyle. The physical activity is reduced. The dietary eating their dietary patterns have changed. The stress levels have increased. Because of all this, the shift has been towards breast cancer from cervical cancer. The topmost cancer in women is breast, followed by cervical cancer. And in men, the most common cancers that we see are oral cavity cancers. If you see, India is a hub of tobacco. There are like lot of people, I mean men, who chew tobacco, or addicted to smoking. Because of that, because of this particular underlying factor of tobacco addiction, or tobacco consumption, we see a lot of oral cavity cancers, and lung cancers are a
They
common.
chew tobacco, right? That's one of the
Yeah,
reasons.
they chew tobacco. And it is because of that, the incidence of oral cancers is very high in India. And especially this is more in the what you call rural countries. If you look at the statistics, a lot of men come with they have like ulcers in the mouth, their presentation, because of that tobacco chewing, constant tobacco chewing, and they're like addicted for years together. So oral cavity cancers are high here.
One of the cancers you can prevent it is cervical cancer. Is there any
Yes.
pap smear testing? They're widely available in the rural and big areas. Is it a common practice now? Pap smear in big cities and small towns, and everybody is a woman are going through that
Yes.
exam quite a
Yes.
bit.
So cervical cancer is, like as you mentioned, this is the most preventable cancer. It is possible, like if we take right measures on time, we can prevent about more than 50% of the cancers can be prevented upfront. Like women can prevent themselves from getting affected with this disease. Cervical and pap smear cervical cancer screening is done. It's a very simple method. I mean, it's like not complicated. It is just you need to take cells from the cervix, scrape cells from the cervix and test it in a lab, which is a very simple process. This does not require a lot of heavy machinery or infrastructure. So there is a pap smear test kit that that will be there. And so with that we can screen a lot of women. Like as I said, mobile screening units are installed these days. And for cervical cancer screening, this will definitely help. Women need not travel all across to different geography, or to different different city to get this tested. So government is definitely taking a lot of initiatives for this. And the cervical screening campaign has rampant. It's like, I mean, it is I'm like very glad to say people, most of the, even in rural areas, people now know about cervical cancer. They know that they can get their pap smear testing done. And apart from pap smear, there is something called HPV DNA testing, which is a little bit expensive side. Which it's not necessary that you do both or replace it. A simple pap smear test also is sufficient. And people, of course, who can afford in urban areas, who can afford, or who want to reduce their frequency of testing, they can go with HPV DNA testing, which is done like once in 5 years. And pap smear testing, it is done like usually once in 3 years. Once a woman crosses 25 years of age, once in 3 years, that can be done. And one more very interesting thing about cervical cancer prevention, a part of it is HPV vaccine. I know you must have heard about HPV vaccine of late now. Even the government, like in the year 2024, 20 last year, so they have indigenous vaccine, cervical cancer vaccine has been, like introduced by our Indian government. Like so this is to, so HPV vaccine is a beautiful invention. If
Correct.
I have to say, because that HPV vaccine can prevent about a majority of cervical cancers.
Correct.
And not just cervical cancer, it also helps in preventing uh, cancers, sexually transmitted infections,
Yeah.
that also. And some oral cavity cancers, especially oropharyngeal cancers, can be prevented with the help of HPV vaccine.
Really,
So
I didn't know that. Yeah. So oral cancers also can be prevented.
oral
That's
or specifically oropharyngeal cancers
okay.
can be prevented. So initially it was that cervical cancer vaccine was, we used to give cervical care. The indication was, young girls like 9 to 14 years of age should receive the vaccine. But now the guidelines are changing, so women between, like girls and women between 9 to 45 can receive their vaccine. So I would like to pass a message to the audience, like if you fall into this age group, and if you are a woman, definitely it is a sign that go take your HPV vaccine at the
Yeah.
nearest center.
Very good. That's a good positive side of that. Second thing, I wanted to ask you the major treatments for the everybody knows major treatments for the cancers or surgery and chemotherapy. The other one, most important one, the radiation therapy. That's where you belong. That's where you are specialized in. So radiation therapy. Tell us a little bit about in India. What are the patients you get after chemotherapy, or what are they go through surgery? When do you get the radiation therapy patients to you at that time? Is a medical
So
oncologist passed to you, or what are the mechanisms in Indian system?
okay, to answer this question, there is like a no straight, there's like no straightforward answer to this. There is like no one liner. So just to brief you, when it comes to oncology treatment per se, I'm not talking about India in general. When it comes to addressing cancer as a disease, it is a multimodality treatment approach. So
Yeah.
that would involve all the specialists like medical, surgical, and radiation. And in most of the cancers, like see, cancer can affect any part of the body, like from head to toe, any part of the body the cancer can develop. But obviously, like we cannot be discussing about like thousands of depending on thousands, there are like 1,000 different types of cancers, but we would talk about the majority of the common cancers, like breast, cervical, oral cavity cancers, lung cancers, GI cancers. So major, there are like a few cancers, that will like account for like 80-90% of the cancers. So of course there are like rare cancers which will have different treatment approach, and they have like a every cancer will have a specified protocol or treatment designed as per the literature or the available studies. So here what happens, in most of the cases, like as I said, we will require radiation, surgery, and chemotherapy at some point or the other. uh, and
Let us talk
especially,
about the radiation part of it. So, one of the things, the biggest requirement for the radiation therapy is the isotopes. You need a radioisotopes. You need how. When I was growing up in India, it's not easy to get them. There was a huge restrictions, a lot of regulations. So, how that's one of the reasons radiation oncology did not grow because of the limitations of the availability of the radioisotopes. How now is it changing now? Is much more easily available like FDG, the isotopes.
so when it comes to the treatment with radiation, there are like there are like certain aspects to it. Like radiation oncology is treating, like
Oh, they're treating.
you're
Sorry
treating,
about the diagnosis I'm talking about.
yeah,
Yeah, you're right.
this,
You don't need isotopes for the
yeah.
treatment, right? Yeah,
So treating with to explain it for a common man, what do you do in radiation oncology?
yeah.
What exactly is, like I would say, we treat you with X-rays. I mean, it's just like, the energy of X rays would be different. Energy of the X rays are higher. And coming to the radioisotopes, that is also an integral part in the cancer management, because these radioisotopes are used in diagnosis. So there is
But
something
they
called,
do brachytherapy that you can put a radioisotope directly on the cancer itself, right? You
yes,
can
yes.
directly,
There
yeah,
are like interconnecting tubes. We have a machine, like when talking about brachytherapy, like let me break it down for you. For brachytherapy, it is like there is a machine, there is a machine which is like connected to the disease with the help of tubes. And we like like for example, like I'll give you, like common cancer is cervical cancer, and brachytherapy is one of the integral treatment part in
yes.
addressing cervical cancer, along with radiation with X-rays. Apart from the external beam radiation therapy, brachytherapy is very important. Like if we have to tell a common people, brachytherapy is something like you give it internally. We call it as internal radiation therapy. So with the help of tubes, the radiation uh, is given to
So
the
my
patient.
question to you is it available? Are they freely?
Yes,
Is it
yes. Brachytherapy is like easily accessible in most of the cancer institutes these days.
okay?
So yes, that scenario has changed. Like a lot
Good.
of cancer institutes have this machine, because keeping cervical cancer in mind, uh, so having brachytherapy is
Let,
uh,
let, let us talk about the beam part of it. Now, we established that brachytherapy. Now, the beams, you're talking about only X-rays. Do you use electrons, proton therapy, electron beams, or gamma knife, gamma rays? There are the how available they are in Hyderabad or any place you're in for the
okay.
radiation oncologist.
Okay, so all this come under a common umbrella called external beam radiation therapy. Okay, like you have talked about proton, electron, these are different modes, but these are all like from an external source. There is a linear accelerator machine which is the external source. From there, the X-rays are developed, and those X-rays are passed into the patients. Like we target wherever we have to give. So that area is specifically targeted. So these are like different types. Like most commonly, we use photon beam therapy for treatment. Like other things are proton, electron, gamma rays. Like these are the little bit on the lesser side, but most commonly photon beam therapy is used. And gamma rays, the what do you call, electron beam therapy is specifically used for surface cancers like skin. If you have to superficial area, if you have to treat or irradiate, then electrons are used. Most commonly for deep seated tumors in the body, photon therapy is used. And gamma rays is something like which is advanced, like uh, used for what do you call, specifically for brain tumors, gamma
Mhm.
knife therapy, that we call. If you have to, because I'm like trying to find ways where the audience can connect. Not all the audience would be would be coming from that established medical background or oncologist background to understand. So gamma knife therapy is specifically, it is a localized targeted therapy for treating the lesions in the brain.
So it's available plenty. They're all
Yeah,
available.
it is
So
available in
except the
most of the.
proton therapy, probably there's the most. But there is a big difference between electron beam therapy and the proton.
Yes.
The proton therapy. Photon therapy is easier. Proton therapy is much more, is a bigger atom, and it is a bigger particle. So it is requires a huge amount of infrastructure required
So,
for that. So
proton beam therapy, this is like, in radiation oncology, this has been the most recent advancement. Recent and very very fascinating advancement that is there. So it is also a form of radiation therapy, but slightly advanced. The advantage of this proton beam therapy compared to the conventional photons that I have mentioned in the beginning a few minutes back, so it is that it has more precision. And the target that we are like trying to treat, the target here is our cancer, like the cancer, the area that we are treating. So the target is better, targeting the tumor is better, and minimizing the damage to the surrounding tissue. See, now in the body, like we cannot just differentiate, we just cannot have a clear cut, okay, differentiate, put a border or put a line, and this is cancerous, this is non-cancerous. That is practically not possible. Though, as an oncologist, as radiation oncologist, our job is to delineate the tumor. We do draw boundaries. We do, draw that, okay, this is the target area and this is the normal structure. But somewhere, at the border, there can be an overlap of normal tissues that can be affected. So,
you
our
know,
ultimate aim is we are trying to prevent the damage to the normal tissues and kill the tumor cells as much as possible. That is what our ultimate aim is.
you are very passionate woman, really passionate about doing something different in the world, in India and in the world. I think I'm going to present a topic and you're going to watch it with me. And then after that, we come back and talk about a little bit about your interest, So let me
Yeah.
present about this woman that that is Rama Vaghmare from Hyderabad joining. She is a really fascinating woman. She's giving a lot of background in Indian scenario. We need to know. So I'm going to present another fascinated woman in the different century. She came out. Her name is. Let me tell you what that is. There is a war going on between. That is a. I Let me see the little bit bigger. Yeah, there is a war. It is a war between the Ukraine and Russia and Ukraine. Yeah, it's a war between Russia and Ukraine. There is a war going on right now, but there was another war. There was a war actually between Russia and Ukraine, 1840s, 1850s. That is. I'm going to show you. That is a little bit of a. Yeah. Let me. Yeah, that war is between the Russia and Ukraine. Happened in the Crimean Peninsula. It's the Crimean Peninsula. There was a war between the Russia and Ukraine. So Crimean Peninsula is across the Black Sea. Turkey is the country. It is called. It is called Ottoman Empire. It is ruled by it was ruled by Ottoman Empire. It was ruled by Ottoman Empire. So Russia is wanted to take over the is actually Crimean Peninsula is ruled by Ottoman Empire, Turkey, but the Russia wants to occupy them like now what is happening now. So England, the Turkey doesn't have the enough army, so they asked for England and France to help them. So England got into the action. The reason England got into the action, they said that they told the Turkish Ottoman Empire told them, if you allow the Russians to come in, eventually they're going to take over India. India is a prized position for England, so they're going to come after India. So England was very nervous about it, and so they wanted to stop the Russians in the Turkish border, in the Ottoman Empire. In the Ottoman Empire, wants to stop them, but it was it was one of the first modern war fought in the among the humans. Is the first. They have railways. They have now they call shells, naval shells, very powerful shells. You can fight them, and then they have railways. The transportation is very good. Telegraph came in. Is already invented. So it is the first modern war for the humans. Is so it was a very it is a big tragedy in making in place. So in this war, it is it is one of the it's what is people dead in this war, not because of the war, not because of they shoot each other or they died from the injuries. Actually, they died from a lot of diseases. This is the first time humans realized that it is a disaster, a huge medical failure. It happened. 500,000 people dead. So how do you know about this? There is a woman like Rama Vaghmare, one woman came out in the picture. Her name is Florence Nightingale. She's a privileged intellect. She's from a very aristocratic family. She's from a really rich family. She was born in Florence, Italy. Her father is a diplomat, an English diplomat in France. Sorry, in Italy. So she was born in Italy. She was named after the city Florence. So Florence Nightingale is intellect. She loved. She was not a nurse in the beginning. A lot of people think she's a nurse. She's a mathematician. She loved mathematics. She's a global citizen. She was born in England, raised in. She was born in Italy. She was of English origin and studied in Germany. So she is a very global citizen. She knows already around the world. So what she studied, she loved mathematics. People didn't know that, but she was learning from a very top people, one of the top mathematicians of that century, because she's already privileged intellect and a very aristocratic family. She got the tutoring by very powerful people. So she learned statistics and mathematics. She loved mathematics. So a lot of people don't know about the Florence Nightingale, about her background. A lot of people think she's just nurse. So she went to then she loved medicine. She went to England, and then Lutheran Hospital. She went to medical training for the nurse training. She started nurses training. At that time, nurses training is a menial job. It's not any respectable job nowadays. But it was she started in Germany. Then she took a 50 woman. So there was a war going on. Five people are dying. English British soldiers are dying in large numbers in the Crimean War between the Russia and England war in the Crimean Peninsula in the Turkish across the Turkish border, Turkish Black Sea. So she took a 50 nurses, all women. She's a very feminist. She took all the nurses, 50 of them. She took them to Turkey, to the borders. Think about that. She's a royal family. She doesn't need to go there. She went there to the borders of the. So she found out, most of the medical catastrophe. She saw most of the diseases are typhoid, typhus, cholera. All these. These are the diseases, common diseases from pathogens, and then bacterial infections, and then large numbers are dying in this crumped hospitals headquarters like a small houses. You see that those are the hospitals they call. They are dying large numbers in the English soldiers. 25% of the people dying after the injury, after they come to the hospital because of the diseases. So she took she is a very smart woman. What she did was she made a pie graph. It's called a rose chart. She made a popular she didn't invent the pie chart, but she did popularize the pie chart actually. No, not too many people were using pie chart before. So she took the pie chart, and then she took the pie chart and showed to the British politicians how disease is killing. Not they're not killed by Russians. She says we are killing. England is killing the British people are killed by British politicians not taking care of them in the hospitals. That's what she said. So she took these charts and she was going to the Westminster Hall, which is a Congress. The politicians were nervous about her. She was very forceful, and she was telling, if you don't support me to find a new hospitals, I'm going to go to the public. I'm going to the press. So British politicians were nervous. They wanted to get rid of her, and they gave her funding to build a hospital in the Turkey in the Crimean War, in the front lines of the war. So they built a Scutari funding for hospital. She acquired a funding for hospital because of the charts. She's a public health professional. She's the first data analyst. She's an epidemiologist, in fact. So she took that. She built a she built she took the actually that her charts are so famous. W. Du Bois from Atlanta, Georgia, where my second city, my hometown, that he went to England, Paris exhibition. He used the discrimination for the blacks in the United States, employment wise and everything. That was so popular in the 1900 World Exhibition, that pie chart inspired by Florence Nightingale. But she built the hospital in Scutari Hospital. So she's not only hospital, she architected the hospital. She's an amazing woman. She was a true architect. What she thought about that is she needed a much more larger rooms, airflow, and then a lot of sunlight. These are all reduces the injuries. And she opened the bigger windows she created, and the lot of the flow of the air. So she was a very scientific woman. So she was actually Scientific American paid a tribute here recently in the COVID time, how powerful she was so she, that she's an architect of. So she also did the scientific experiments. How the air quality of the air. If she has a lime water, if it get thickens out, it is a lot of carbon dioxide there. So she was doing 2,000 to 5,000 cubic feet air has to be um, trans move around in the hall. So she put the fans and everything to move the air to injuries. So she was very forceful woman. She dramatically reduced the 65% of the mortality rate to 2% with the employing these new techniques and the new hospital systems, all those things. So she was COVID, the Scientific American paid a tribute to her. She's an architect, the first architect of the hospitals. In fact, that's what they said. She's a truly an architect. She also did a actually first hospital, actually a mobile hospital. She's the field hospital. She was the architect of that too. She inspired all of them. They created exam room inside. Those hospital in 1856. Think about that, guys. And she created a mobile hospital in 1856. So she was fell ill. She came back to she went back to England. She was not feeling well. So she started an interoperability system. People don't know this. She is a very fascinated about statistics and data. So created a unified forms of data collection. What she said, that all London hospitals has to submit all the data when the patient get admitted, how long they were there, when they are discharged, what kind of diseases they have. So she created a very statistical epidemiology, statistical thing, uniform. She created a first interoperability system. She is the first initiator of the interoperability systems among the healthcare systems. She is the mother of all of that. She was she was She was a royal. So American Statistical Society gave honorary membership. She could not travel to America, but they went there and gave an honorary membership to Florence Nightingale. She was the founder of the Royal Statistical Society. It's a very few know. This is one of the things is we trivialize the woman. We did not pay attention to woman's progress. Everybody says she's a lady with a lamp. She's a prolific writer. She wrote two books. One is the notebooks, and one of they both in the United States, both sides, civilian. When there was a war going on between the Union and the Southern Confederate War, both used the notes from here. They build the hospitals on her architecture. In fact, she has a very influential in the. She's one of the leading figures in the science. That she was a big voice in that one. So she's in India, for example. She did not go to India, but when the mutiny came in one day, oh, British soldiers were killing. British soldiers were killed by Indian mutiny. She said that actually British are getting killed more by diseases rather than Indian soldiers. And she gave a comprehensive sanitation plan to India. She wrote a 2,000 pages book for sanitation plan for India, and then she started a sanitation board. She was inspired. She told the Bombay. They started the Mumbai. Now they started the sanitation things there. The board because of her. So she is everywhere. She's a really a founder of medical tourism. Actually, she is the first medical tourism. She started from Switzerland to the Turkey. She said that a lot cheaper, a lot better. You get a lot of treatment, cheaper than she was starting initiated first medical tourism. She introduced into the Florence Nightingale. So she's a public health advocate. You know, she said that she's a public health advocate, innovator, architect, data analyst, social reformer, and a nurse. Is a lady with a lamp is the last one. I would say that is she not the first that one. Actually, she's popular with the lady with the lamp, but for me, she was all of them together. She's a. I say that she's a very compassionate woman. I stand at the altar of a murdered man, and while I live, I fight their cause. So the beautiful saying that people I have to be there for them, for the dead man. So I have to fight for their cause. So she was the symbol of caring. Same time, she was a very well done. She orchestrated the entire process. She's a mover, shaker. One of the tribute to her. She's one of my heroes. And then we want a heroes like Rama. I'll bring Rama. We wanted to change the world. We need people like young people like Rama to be there to make a difference. So, what do you think, Rama?
Thank you, Mr. Ranam Raju. Like I've known about Florence Nightingale, but there were like few details that I did not know. Thank you for enlightening me on that. And definitely, she has like revolutionized the healthcare and empowered a lot of empowered and encouraged, and have she's been like an inspiration to a lot of women uh, going forward. To do what they feel like, not holding themselves back, like believe in themselves, and just go ahead and do it.
Yeah,
So
she's
I totally
definitely
agree.
inspiration
She's a
for all of
hero
us.
and an inspiration.
Yeah, she's truly inspiration. So that you're inspiration to the next generation. You're giving a young woman that and doing you wanted to change the scene of the. That's the only way they start somewhere, right? In India, the cancer is like a. Let us talk about the stigma attached to cancer. I saw your article. I was so impressed by that. You said that what is a stigma in the United States? Also, there is a lot of stigma there for the cancer, but in India, it's much worse. Tell us a little bit about stigma associated with the cancer, and how do we need to educate them. So, a little bit shed a light on that one, if you don't mind.
Yeah. So this is one thing, the most limiting the cancer stigma. It is one of the most limiting factor, preventing people for coming and talking and receiving the treatment on time. So initially, when I have like joined the specialty, so I have like seen a lot of women, especially this is there in women, compared to men, the cancer stigma that it more commonly lies in women, because uh, women are diagnosed, common cancers are breast and cervical cancers, and they fear that the moment this their diagnosis is revealed, they feel that they will be abandoned by their own people and the society. And unfortunately, that has been happening from the real life experiences, like what they have witnessed and seen. That fear is like instilled deep in their minds. So there was this, in the initial in the first 6 months of my career in radiation oncology as a postgraduate student, so there was a woman with breast cancer who had like come in the fourth stage of her disease. So I was just a naive, very bud I mean, I was very new to this specialty, and we were like very curious in digging the history, like what, when it started, how it started, and the patient's journey, the medical history and all. So just like I was just out of curiosity, I asked her like, it was like very casually asked her, like, why did you even come in stage for this? You could have come like long back, because I was very new. Then she just opened up in the native language. She was obviously from a remote village somewhere in Andhra. She said, "Ma'am, madam, I was very scared that if I like told somebody that I have a lump in my breast, or that I have an issue with regards to a body part in a female that is like associated with a lot of self esteem, and that is like a what do you call it, identity for a woman. So I thought my own family members would disown me, and I would be abandoned, or
Yeah.
considered as a deadly, I would be transmitting the disease. So she had a lot in her mind, that she opened up that day. Then I realized she's not just one woman who's affected with cancer, who coming from a remote place. There are like a lot of women, and people don't even talk about it.
Hmm.
So that day I realized, how much fear and stigma that is there. We sitting in the city, we think that reading and doing, practicing with everything, with available infrastructure, thinking no, cancer can be tackled at different stages. At this stage we have this treatment available, but the root cause, like where it is originating, we are like, we have somewhere as a society we have failed to address that. So that is why for women especially, that addressing helping them understand that cancer is a disease, just like diabetes or hypertension. Cancer is also a disease. It has nothing to do with, it is not contagious, it is not a transmittable disease. It is to make them realize that. And like as I've mentioned, I think we were like talking when we got introduced, before even my own family, there are like people who have like been diagnosed with cancer in distant relatives. But you you would be shocked to listen, shocked to know that I was not the first point of contact that they reached out to me. I, in fact, to know once their treatment had started at some other place, they had gone to a region which was like not in the vicinity. Instead of taking treatment in the available, they were like so scared of that fear. Okay, what if they come up? She has been diagnosed with cancer. One of my distant aunt or relative. I would not like get into more details of her identity. Like, okay, she went to some far off place, which is like 100 kilometers away from the city to get the treatment done. I was shocked, like when I got to know, why didn't you reach out to me? You are family, how would I reach out to, how would family react? And none of the close family members knew about it. So I was like, even today, in this was somewhere in 2019 or 2020, during that, okay, even in this day when we have like everything available, just a phone call away, I'm just a phone call away. But
It's a
still,
very secretive system.
very
In
secret.
my family also, I see that it's a
Yes,
very everything they want to be sick. I
very
don't know stigma. Is a stigma or something that psychological? I'm not sure what is
psychological.
cultural. All mixed them together, I
So that
think.
fear, they think the moment the cancer, they hear the word cancer, they feel like, it's a death sentence. Okay, I'm not gonna survive. There is nothing that can be done. Okay, everything is like gone out of our control. It's out of our hands. There are like lot of things. There is like a lot of psychological impact because of the social barriers and cultural barriers. Like, every family, there is like a different different culture that they come from, different belief system. that they come from. So making them understand that, if any part of your body is affected, like, you come up openly and talk about if your blood sugar levels are high, if you have blood pressure, you come up and talk. It is something like that. It is just because, you have a lump in the breast, or a problem somewhere in the body, like, you should not be talking, or there should not be any hesitation. So uh,
Do they have patient support groups, like all the groups together talk each other and help each other, or some psychological help? Psychologists or counselor therapies are available to them, or what are the situation there in India for those kind of?
so yes, definitely. So this was like not existing few years back, until few years back, but of late, as the treatment is advancing, there is not just, just treating with giving them medicine, giving radiation, surgery, chemotherapy. It's not going to solve the problem in dealing with oncology, yeah, in dealing with cancer management. So an integral part is addressing the psychosocial aspect of the patient, like, where they come from. Every patient is different, you know p- say a patient, there are like, if there are like two patients diagnosed with the same condition, same disease, same stage, but their way, the way they respond to the disease, or the way accept the diagnosis, the way they process it, can be entirely different. So definitely there have been, like, of late there have been lot of cancer support groups available. And in lot of hospitals these days, they are, we are making sure all the cancer patients receive proper counseling, not just, the treatment, but that psychological counseling is also given, because that also plays an important role in the management. If we are like not addressing that aspect, no matter how much treatment you give, you're just treating the you're just giving medicines, you're just giving medicines in the body, but you're like not trying to what the mental aspect, if that is not there, the
Can you
response would not be that good.
can you do quickly that? What is your passions? What do you want to do? Advance your career or advance things? What do you like to do? Very quickly.
So, I would see. I'm a radiation oncologist, which is just one part of oncology. I mean, as by my degree, but then I do not want to limit myself only to radiation oncology. So there is, oncology has different segments in it. Like, there are like lot of loopholes are there when it comes to covering the gaps in the oncology market in India specifically. And advancements, when it happens, it is like a lot different coming to India, when you compare to the Western countries. So there are like a lot of things. Cancer research is there. So I would want to be a part of revolutionizing the oncology care in India.
The
That is
workflow management side of it, the
Yes,
workflow and the
I mean,
management you
I
want
want
to.
to cover, I aim to cover the gaps, because as a in the last few years, the real life, after completing my post graduation, when I jumped into the real picture, the real world of practicing, then I realized there are like a lot of things that need to be addressed as a
I'm going to.
clinician. uh,
I'm,
clinician we doctors are already, we know that nobody can take that skill out of our mind,
I'm
but
glad to connect with you.
addressing
Some
the
people that were forefront from United States. I spoke with a lot of people from radiation oncology and oncology background. But anyway, so you're from my hometown. You're the village. What do you do in the weekend? You go to Tank Bond. You do what is the biryani? Hyderabad biryani. What do you do?
so
Do you know this? There is another lady came from 1888, 85 from Maharashtrian woman, Anandi Joshi, the United States. She got the first MD.
first doctor,
So
yeah,
you are
first one.
Maharashtrian, same background. So what do you do in the weekends,
I
Rama?
am I am like a person who cannot sit idle. I mean, I just cannot sit idle. It's very difficult. So, I mean, the moment I find, I just take my car and run away. I just go on long drives. I like exploring places. I know it's not always possible to travel long distance. Take a flight, go. I do that as and when my schedule allows me. But then I like exploring the local places, like going to nearby villages, small villages, just
Really?
connecting with nature. So I love doing that, exploring nearby places. And I'm a yoga enthusiast. So I take a lot of interest in the holistic well-being, like what are the ways that we can incorporate in the well-being, apart from, see, the clinical aspect, the healthcare. As a physician, there are a lot of things that I can do, but there is like the holistic component is there. So I try to work on that, and encourage people to follow a healthy lifestyle. With I want to be a real life example. Like, before I tell people anything, I follow it and then only preach.
Thank you so much, Rama. You are fascinating to talk with. You're a young woman, energetic and passionate. We keep coming back. I love to talk with you more, and you are really wonderful to talk with you. So much. Thank you so much. I'm truly honored to have you.
Yeah, thank you so much for having me here. Even I enjoyed the talk. I know this has been like more of like impromptu, but then I really love the discussion, and I look forward for more discussions where the audience can connect with the talk. There is like no point in talking the medical jargon, or specifying something. We would want to get to the audience something they can connect, and they can there can be some change. They can take home some points with our discussion.
Thank you so much. I am really appreciated. Good night, all of you, and stay 1 second.
Telling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.